Hey guys, it's Dr. Danny Shaban with the unknown or unnamed podcast. We're still thinking about what we're going to name it. So we're going to do our podcast today on, what are we doing, Melissa?
We're going to talk pregnancy.
All right, so we'll talk about pregnancy today. And we'll probably just go through each trimester in pregnancy and what to expect. Our practice is a little bit different than the majority of practices in our area, because when I first set up this practice in 2002, I wanted it to be a practice that was more about patient and family and getting these patients to understand that every single one of our patients that comes into our practice is our family. So we want it to be more of one-on-one bonding with the patient and her husband, and that way they'd have a better experience. So start off with the first trimester.
Yeah. I mean, so why don't you even start out from even before that? What about, like, what do people need to know? What do women need to know about getting pregnant and what they should do to be healthy, even leading to pregnancy?
So, I think we'll break it down in future podcasts in regards to that. But I think that one of the basic stuff is just being healthy. If I have a patient who's obese or overweight, we talk about, hey, listen, you're going to be gaining between 20 and 30 pounds during this pregnancy. And if you're already 40 pounds overweight, let's figure out a way to get the weight down prior to getting pregnant. So we talk about diet, decreasing carbs, increased protein intake, increasing activity, working out. We look at meal preps. We'll go through all that prior to them getting pregnant. And it's a good question you ask, because then I also talk about like their menstrual cycle, ovulation. Because if you're already having irregular cycles, you're not knowing when you're ovulating, we try to get those all regulated. And we talk about, like, when do you ovulate? Do you ovulate on day 14, or are you ovulating on day 18 or 20? So we'll go through all that. The other thing we talk about is just taking your prenatal vitamins. Some patients are taking probiotics, vitamin B6, and those are all healthy for you.
Are there any other supplements like magnesium, folate, anything else that's really important?
I mean, the great thing about a lot of these prenatals now, there's enough folate in them, unless you've had like a first trimester miscarriage, a neural tube defect, then we'll increase your folate. Iron doesn't, I don't really start iron unless you're already anemic. There's a delusional effect like in the third trimester where we'll add iron, but the last thing I freaking want is someone to be on iron in the first trimester and constipated.
Yeah.
So I don't really start it that early.
Okay, good. So then let's just say that magical moment happens and someone has a positive home pregnancy test. What do?
So the one thing that we do in our practice is we say for our patients, as soon as you find out you're pregnant, just notify us. We'll get you to come in. There's some of this OB groups will say, oh, don't come in until you're at least 8 to 10 weeks. But we bring our patients in early. We confirm that they're pregnant. Either we'll do an abdominal or a vaginal ultrasound to check for a gestational sac, a fetal heartbeat, and then we'll go from there. And on that first visit, we'll draw their complete OB panel. We'll make sure we know the patient's blood type, their anemia levels, their electrolytes. We'll go through and do the RPR, hepatitis, and STD screening and all that on the first visit. And then answer any questions that the patient and her husband might have or her partner might have. We'll go through all that, and then we bring you back in 2 to 3 weeks later just to make sure everything is going well.
Okay. So what should someone expect at that first visit after we've confirmed the pregnancy and, we're starting their OB care?
So what we'll tend to do is if we're able to, we'll tend to do an ultrasound just to confirm it's an intrauterine pregnancy. It's in the right place, so that it's not in the fallopian tubes, or it's not too early of a pregnancy where we can't pick it up. But besides confirming that, we'll also, if we see a pregnancy in the uterus with a heartbeat, we'll give the patient the picture and just celebrate a little bit, just rest at ease. The other thing that we tend to talk about is there's a lot of new blood tests that are out there. One of the tests that we were doing about 10 years ago. And then now the insurance companies have approved it for all women that are pregnant, is we do like a Materna 21 or a DNA test in the first trimester as early as 9 weeks, where we can tell the patient with 99% certainty she's not having a baby with Downs or trisomy. And we can tell you with 100% certainty after that 9 weeks, because it's a DNA test, if it's a boy or a girl, if you want to know. Which most patients, they usually get a scratch card from our office and they'll do a gender reveal and all that.
Yeah.
This is supposed to be an incredible time in a woman's life and her partner's life. So what we try to do is celebrate the pregnancy. So we'll do stuff like that. We'll talk about the upcoming visits, what to expect in the second trimester, third trimester. But the first trimester is just, let's celebrate, because by the time you see a heartbeat, there's a 95+% chance that this is going to be a normal pregnancy. And we try to reiterate that with the patient.
That's pretty amazing. So starting in that first trimester, are there any concerns that patients need to watch out for of, anything happening during the pregnancy?
If I have a patient who's had multiple miscarriages in the past, we tend to follow those patients a lot more carefully. So we'll bring them back every week or every 2 weeks just to ward off evil spirits. And we'll also talk about progesterone replacement, because some of the studies in the past have shown that if you've had one or more miscarriages in the past, it might be due to a progesterone deficit, or if you've even spotted in the first trimester, we'll take a look at the progesterone levels. The other thing to do is just look at the patient's activity. The one common question I get, which is probably a question I would have if I was a woman and pregnant, because I don't do it now, is working out. Everybody wants to get in shape once they're pregnant. And I usually tell patients, continue doing what you normally were doing. If you were going to the gym 7 days a week, I'm totally fine with you going 7 days a week. But if you've never been to the gym before, your BMI is like 40, I don't want you doing CrossFit 5 days a week, 6 days a week. You don't want to start something you weren't doing. Now, do I not want you to walk or start exercise? No, I don't mean it that way. We want you to walk. We want you to exercise. Just don't become a strenuous activity. You're not going to run the marathon once you're pregnant, and if you haven't run it before.
Okay, that's really good to know. And what about the development of the baby? I mean, is there, at that stage during the first trimester, what can moms expect to see when they have their ultrasounds?
So by the time we usually see a patient, she's 5 to 6 weeks pregnant. So we'll definitely be able to see with a vaginal ultrasound the baby's heartbeat. So we'll see the heartbeat, and then we give the patient literature and books to show like how big the baby is at this gestation, how big it's a tadpole, is it 1 to 2 centimeters. So we tend to do that. But yes, definitely by 5 to 6 weeks, we should be able to see the heartbeat with no problem. And then once we're at 12 weeks, you can see the baby pretty much forming. You'll see the arms, the legs of the baby.
Excellent. So then moving into the second trimester, tell us about that. What do you do? What should a patient expect when they come in during the second trimester?
So in the second trimester, it's just a watch. I call it the wait and see. We'll do one blood test in the second trimester, and that's the AFP, just to make sure that baby's not at risk for spina bifida. In our practice, we tend to just quickly take a look at the baby. I always like to see my babies and make sure they look good and the fluid looks good. So we'll definitely be able to see a baby bouncing around in there. And usually by the second trimester, the mom will start feeling like a flutter, a butterfly, or a tingling sensation in the pelvis. And by the end of the second trimester, she'll definitely be feeling the baby kicking. We also take a look in the second trimester, where's the placenta located? Is it on the top of the uterus, on the back, or the fundus? So we'll take a look and make sure that it's not covering the cervix.
Why is that important?
It's really important, especially in patients, if it's covering the cervix completely. It's called a previa. So it's basically blocking the way of the baby from an exit strategy. So, and they tend to move as the placenta, as the uterus is growing, it's pulling the placenta off of it. but we keep a close eye. If the patient's placenta is completely covering in the third trimester or near term, then we talk about, do we need to do a C-section? Because that's the last thing we want to come out of the uterus. We want the baby first, then the placenta. If the placenta comes out first, that's the lifeline. So we don't want that coming out. And maybe we'll do a podcast on placenta previa and all that in the next time.
Okay. So also during the second trimester, I know typically an anatomy scan gets done. So can you explain a little bit about that and what individual can expect?
Yeah. So the running joke in our practice is that's the complete ultrasound. The other ones are for the patients and the providers just to smile and laugh and joke that we see the baby. The ultrasound that's done between 19 and 21 weeks, or the anatomy scan in our practice, that's when we're looking at the heart, the lungs, the brain. We want to make sure the brain's developing, that there's 2 lungs, 2 kidneys, a bladder is there. We look at the heart, the valves of the heart, the chambers of the heart. We look at the bowels, make sure the bowels are in the right location. So it's probably an ultrasound that takes about 45 minutes to almost an hour in some cases for our patients, but it gives us a complete detailed exam. So we take that with the blood work and we reassure our mothers that they're having a beautiful baby.
Yeah, I know moms love to see that one, so it's very exciting for them.
And we usually want you to bring a partner or a family member because then you can enjoy it a little bit more.
Yeah, absolutely. It's so exciting. Well, good. And then, of course, leading that into the third trimester.
So the third trimester is the stage that I always talk about, the almost like, especially when we get to like 35, 36 weeks, I call it the miserable stage, where mothers aren't sleeping, they're tired all the time. And the running joke is God's doing this to you, keeping you up all night, because once the baby's born, you're up all night. So it's a training session. But we just make sure in the third trimester that especially your blood pressure is doing well, you're not having swelling, fluid retention, because we worry about a thing called preeclampsia. And in the olden days, they used to call it toxemia. But it's when your blood pressure goes up and it can decrease the amount of blood flow to the placenta and turn to the baby. So we keep an eye on all this stuff. But and it's also, I tend to do a lot of my own scans when I see my patients in the third trimester every week, because I want to make sure the fluid level's good, the baby's looking good, and baby's moving well. And we just start planning on the delivery process. So during the third trimester, we talk about like, where are we going to have this baby? Because in our practice, we deliver at 5 different hospitals. So we talk with the patient and her partner, like, which hospital do you want to go to? This is what's going to happen the night that you go into labor. This is the phone number you're going to call. So we review all that. And then when we get to 36 weeks, we do a thing called a group B strep. And we make sure that the vaginal swab is done for group B strep, because if you test positive for group B strep, it just means that when you're in labor, we give you an antibiotic 2 doses prior to delivery. So how often do we see group B strep? It's probably 40% of patients carry group B strep naturally, and it colonizes from the rectum. So I try to reassure patients, just because you're group B strep positive, it's not the end of the world. That's totally normal. And we really didn't even start testing or treating for group B strep until like 2000. I was in residency in 98, and then they started to test for group B strep. And they said, oh, well, if we prophylactically treat every mother for group B strep that's test positive, then we can prevent group B strep infection in the baby. So it's not a big deal. I try to reassure my patients that everything is going to be fine. And then when we get to a point after 36 weeks, if a patient's having pressure or pain, I'll check her and see how dilated she is. Since I do a lot of my own ultrasounds, I don't necessarily check my patients on every single visit, because if I can see your baby's head, I know it's not delivering. So there's no reason to check.
Okay. Can you explain, to everyone just a little difference between, C-sections versus vaginal deliveries? What's the preference? Why is everyone so focused on, trying to do a vaginal birth versus a C-section from a medical aspect?
Well, I think in general, it goes in waves, but in general, which has an easier recovery back to normal? Of course, it's a vaginal delivery. I mean, and our ultimate goal as a practice and as a provider is to have a beautiful mother and a beautiful baby. If you go to any provider or any practice that has a different attitude, then you really should look at a different provider or practice. So my ultimate goal is to have the beautiful mother and a beautiful baby. And if it means, which is my ultimate goal, is to deliver vaginally, I think that's great. But if I see an indication to do a C-section, my patients never really question, because I've built that relationship with them that they know I'm doing what's in their best interest in their baby. Why are C-sections important? Well, over the past 50 years, C-section morbidity and mortality has gone down because we've got antibiotics, it's gotten cleaner, anesthesia is much better because they do epidurals and spinals versus general anesthesia. We have medication to get the uterus to contract. So as far as complications, we don't see them as much anymore. But again, you want to try to deliver vaginally. But what are some of the indications for a C-section in a normal, healthy patient? I mean, some of the stuff is the baby is too big. I mean, to come through vaginally, you can get shoulder dystocia, pelvic trauma. If I have a patient who says, my last baby was delivered vaginally and I tore so bad, it took me a year to recover from from the surgeries they had to do to repair, or I had a birth trauma where the baby had a shoulder dystocia or broken clavicle, or I had a fractured pelvis during the delivery, of course I'm going to do a C-section or recommend a C-section. I'm not going to try to push the patient. And then last but not least, it's a woman's choice. I've had patients that say, I don't want to have a vaginal delivery, I want a C-section. And that's a woman's right to choose her mode of delivery. But we talk about that throughout the pregnancy. It's not a discussion that's made at 38 weeks, like, oh my God, you never talked to me about delivering vaginally or not. And that's the great thing about practices like ours, is that we have midwives, we have nurse practitioners, we have PAs, and we have physicians. And the big thing is the way I set this practice up is I didn't want to have a midwifery practice that didn't communicate with the doctors or the nurse practitioners. So we all work as a team. So I have a midwife that works directly with me on certain days of the week. So do the other providers. But throughout the day, I'll get text messages from my midwives and nurse practitioners, or they'll come over to me in the office and review a patient. So we have an amazing relationship. So, and I always joke around and say I have my midwifery patients that want a midwife, and I have patients who want a midwife, but they want to make sure that the doctor is aware of their whole situation. So we work as a team, and it works out well for our practice.
And I know hopefully maybe we can talk about this at a later podcast, but can you just go over brief differences between seeing a midwife versus maybe seeing a doctor?
Well, I think that what I try to explain to my friends and colleagues and people that aren't in the medical field as well is, and healthcare is changing in this country. And Melissa's just trying to bait me into throwing the F-bomb out about this country when it comes to healthcare and women's health. But what's happening is these bastards are decreasing reimbursements to the hospitals, to the physicians. So what we're having is these pop-up schools all around the United States, and they're popping up with NP schools, PA schools. And I'm not saying they're not great providers. I think in the right context, there are amazing providers. Midwives have a great standing. Midwives have been around forever. So when we hire a nurse practitioner or a midwife, we have them work directly with a physician, because I don't want to miss anything. And again, it goes back to our patients are our family. So, and I don't want a patient to assume that the provider they're seeing has that same level of education as an MD. So we work hand in hand, and we make sure the patient knows who they're seeing. I had a family member of mine go to, I call them a doc in the box. And they saw a provider, and the provider said, oh, you need to be on this antibiotic. So then they went back 2 days later, saw another provider, and they said, oh, you're on the wrong antibiotic. Then I finally looked. So I think Midwifery is amazing, especially for normal deliveries. If I have a patient who has an uncomplicated pregnancy who wants a midwifery delivery, I think it is the greatest thing. I think they have a good outcome in our practice with our patients. It's calming, it's soothing. And the one thing our patients rest assured is that if anything is going on during the labor process, that midwife is in direct communication with one of the doctors in the practice. So I think it works out well. But just get ready. Healthcare is changing in this country to where we're going to see a lot of changes. And what's happening is, think of it this way, and I have one of my kids is going into med school hopefully in the future, but med school is expensive. And then you hear these bullshit politicians out there talking about giving you a $10,000 reimbursement for your student loans. Can anyone in this world find me a person that went to grad school or went to college that only has $10,000 in student loans? Hasn't anybody called out the bullshit and how this is just like trying to save face? What I think we should do as a country is look at these institutions who are teaching the same language that we've had for hundreds of years, teaching the same math that we've had for hundreds of years, but have raised tuition by 1,000%. Why isn't anybody talking to them? The reason why is they have great lobbyists, where we as Americans and students don't have those lobbyists. So I knew you were going to do this, but it sort of pisses me off when, like, I finished med school and I owed over $300,000 in student loans. So think of it. Why do you want to go to med school and owe $300,000 to be paid less money, to have less respect? I mean, I think things are going to change in this country, and we've got to step up to the plate and call these politicians out, call these insurance companies out, just call everybody out. I mean, it's total BS in this country that you're going to give me $10,000 for a student loan and I owe $300. And by the way, just look at the fine print. It says if you refinanced your loan, you don't get the $10,000. So I call bullshit on all of them. Okay.
Well, isn't that all part of it? So, unfortunately. So, do you want to keep talking a little political here and talk about women's rights and right to choose?
No, because we're going to save that for another podcast. But the one thing I can definitely tell you is I believe that every woman has a right to choose what she wants to do with her body. She has to answer to her own God one day. But I also don't believe that you should be able to do what you want at 30 weeks pregnant. So that's a little political. But no, we'll talk about it at a later date. With that being said, I'll see you on the next podcast. Take care, guys. Have a great week. Bye. Oh, by the way, the Vikings won this week.